And now the last presentation of the session, role of physiology and intravascular imaging during intervention, complementary or redundant. Greg Stone.
Well, hello, everybody. So this talk is actually kind of specific to the black box of what happens in the cath lab. So you might think that it's going to be of major interest to the interventional geeks in the audience, but I think it actually is really complementary to the talks that you just heard before, and I think it'll shine some additional light and some additional insights that have even a lot to do with both primary and secondary prevention, as well as improving outcomes for revascularization. These are my relevant disclosures. So I was supposed to talk about intravascular imaging and physiology. Are they complementary or redundant? So first of all, let's get that out of the way. They're complementary. And in fact, sometimes they're actually competitive, but they're not redundant. So what are the facts and how do we use intravascular imaging and physiology today? Well, we use them first for lesion selection for PCI or revascularization because there's atherosclerosis all over the coronary tree. And sometimes the lesions are mild, sometimes moderate, sometimes severe. We have to decide which lesions are likely to be causing symptoms in that patient, and then which lesions are likely to go on and become unstable, causing acute coronary syndrome, myocardial infarction, or cardiac death. And for lesion selection for PCI, in general, for stable coronary artery disease, physiology is the king. It's kind of the gold standard. That's the P here. And it's used more than intravascular imaging, except possibly for left main disease, where intravascular imaging is at least as good as physiology. Now, for acute coronary syndromes, there's kind of been an evolutionary a way of thought, and we have to think about, one, the culprit lesion, what actually caused the acute coronary syndrome, and it's not always obvious from the angiogram, and in that case, to identify the culprit lesion, intravascular imaging is clearly superior to physiology. And then we've got to think about treating all the other bystander lesions in the coronary tree, and to identify those that may be placing the patients at risk, we can use both intravascular imaging and physiology, and I give intravascular imaging perhaps a slight nod. Now, once we get into the procedure, we have to plan the PCI. And here now, intravascular imaging is going to be the primary tool we use beyond angiography. So we, one, have to decide which lesions can we just treat and put a stent into, or which do we need that are heavily calcified or thrombotic, that we need so-called lesion preparation techniques to get an optimal result. And intravascular imaging will identify those lesions better than angiography. And then we have to optimally select the best stent size and the best stent length. And again, intravascular imaging will do that. And then we need to optimize our results. So we can use intravascular imaging to assess stent expansion, whether it's opposed to the vessel or not, whether there's any tissue protruding through the struts, particularly thrombus. And then we can also look at edge issues that can cause problems, either acutely or in the future, including dissections or untreated reference segment disease. And we often can't see these things with angiography. It's a really limited gold standard. So intravascular imaging leads to better outcomes, and I'll show you some of that data. So let's look at first these physiology applications in the cath lab. So the first fact, and you heard about these studies before, the DEFER FAME1 and FAME2 studies, which were performed 1 to 2 decades ago, established the role of fractional flow reserve, that's intracoronary physiology, to guide PCI lesion selection. And then, to do FFR, we actually have to give adenosine. We have to create coronary hyperemia, which is costly, takes time, and causes side effects in the patients. And so there's new techniques now that are non-hyperemic physiologic techniques to assess lesions in the cath lab. And there have been 2 big randomized trials showing that they're pretty equivalent to fractional flow reserve. And so physiology has in all the guidelines, class 1 level of evidence in stable patients to select lesions for intervention if they're abnormal results and to leave them alone if they're normal results. But that's mostly in stable coronary disease. So this was the FAME trial, the deferral trial, the deferral randomized trial of non-ischemic lesions in stable coronary disease. And if you defer lesions, you can not stent about 1/3 of the lesions that you were going to stent, and that leads to actually lower adverse event outcomes, and you would put in fewer stents, you save costs. It was a big win-win. Now, when you follow those patients out to 5 years, there really was no longer any difference in events, and actually this was all done with first-generation drug-eluting stents. If you were to redo this trial right now with the current stents that we use in the cath lab, there'd be no difference in MACE, either early or late, but you would save some money, and nobody wants to do unnecessary stenting. Now, a little more definitive was this FAME-2 trial that looked at ischemic lesions with an abnormal fractional flow reserve and said, should we treat those with stents, first and second generation stents, or should we go ahead and treat them medically? And as Dr. Narula mentioned, that trial was stopped early after only 888 patients were enrolled because there was a high incidence of patients becoming unstable and needing repeat revascularization if you would treat those patients medically. Now, this trial has gotten criticism. It was an open-label trial. It was stopped early, and so it prevented seeing whether there were differences in myocardial infarction early on. But nonetheless, it was really pretty widely accepted that if you've got ischemic lesions in symptomatic patients, that you can treat the ischemic lesions and actually get results after PCI that are very similar to background coronary disease in patients without ischemic lesions that were followed in a registry. When you follow those patients for 5-year follow-up, these benefits were preserved. And in fact, if you looked at non-urgent revascularization, which was not in the MACE endpoint, there's a huge, huge difference. You just can't leave patients having symptoms and ischemic lesions, whether people are going to treat them because they know they're ischemic and they know they're significant lesions versus the truly causing symptoms we can debate. But pretty much ischemic lesions, symptoms, stable coronary disease, we treat them. Now, the new kid on the block that you'll hear about a lot in the next few years is angiographic FFR. And you can use the angiographic velocity of flow and other patterns in the cath lab to simulate what would be FFR using a pressure wire. And there's at least 4 different competitive systems that are doing this. I've worked with the system called the Pulse system. And again, you do a 3D reconstruction, and then you can create an angiographic FFR picture without using hyperemia. And it's very fast with the current system. We actually ran the large outcomes trial in this called FAVOR-3 China, which was 830 patients with mostly stable coronary disease randomized to this so-called QFR-guided lesion selection strategy versus angiographic-guided lesion selection strategy. And there were big advantages to selectively treating the lesions that needed to be treated because they were ischemic with angiographic FFR and not treating the ones that weren't ischemic. And there were early advantages and there were late advantages as well. Now, a fact that a lot of people don't want to acknowledge, though, about physiology is a lot of those studies were a decade ago. And if you look at the most recent studies that have been done in the last 2 or 3 years, they're questioning the utility of pre-PCI physiologic assessment for lesion selection compared with angiography or intravascular imaging, especially in the patients with acute coronary syndromes. And here are 5 trials that were negative. 3 of them were FFR versus angiography, and 2 of them were FFR versus intravascular imaging. And I'll show you some of these quickly. So this was the FUTURE trial, which people actually discounted. It was 1,728 patients with multivessel disease, half of whom had acute coronary syndromes, randomized to FFR versus angiographic guided lesion selection. And this trial was actually stopped early because of increased mortality in the FFR guided arm. Now, maybe it shouldn't have been stopped early because when they finally got all the data in, the p-value was only 0.06 for mortality, but there was absolutely no benefit of FFR-guided lesion selection in this study. In the Ripcord 2 study, they used 3-vessel physiology compared to angiographic guidance to try to determine which lesion should undergo revascularization with PCI, and there were absolutely no differences, again, in MACE or in quality of life. Now, in the Flower MI trial, which to me was actually the most interesting study of all, these were all patients with STEMI. So these are the hottest patients in whom have the most background vulnerable plaques. And I will talk about that a little bit in the future, in 10 minutes, but you heard about that from Jagat. And here they took 1,163 patients with recent STEMI, successfully treated by primary PCI, and then they had background intermediate and multivessel disease lesions. And they said, should we treat those lesions if they were significant or with either an angiographic strategy, greater than 70% stenosis, treat them, or should we use FFR? And with FFR, they were able to defer treating about 1/3 of the lesions. So there was no difference in these two strategies. If anything, the angiographic-guided PCI strategy seemed to be a little bit better, and this was published in the New England Journal. And any cardiovascular rehospitalizations were actually more common with the FFR-guided strategy. And the reason was, if you left those lesions alone, those third of lesions that got left alone, they had a high rate of becoming unstable, much more so than if you treated them. And that actually drove these increased cardiovascular rehospitalizations. And I'll come back to why that is in the future. Now let's look at PCI intravascular imaging applications as practiced today. So fact one, intravascular ultrasound and optical coherence tomography are useful for procedural guidance to reduce ischemic events. And I'll show you this data. They're currently class 2A in the guidelines, and hopefully they'll move to class 1 in the guidelines with new data that was just presented at the European Society of Cardiology meeting. In addition, pre-PCI intravascular ultrasound has greater utility than angiography in assessing left main severity, and post-PCI IVUS or OCT should be used to assess the mechanisms of stent failure, and again, class 2A in the guidelines. So there was, as I mentioned, there were 5 new studies of intravascular imaging versus angiography guided or against multiple different techniques that were presented at the ESC. And so we actually performed an updated, sophisticated network meta-analysis of all of these trials. And there have now been 22 randomized trials of intravascular imaging guidance published between 2010 and 2023 in 15,964 patients, ranging from 85 to 2,487. That was our most recent Illumian 4 trial. And this shows you in the 4 different types of arms of the number of patients, and the longest follow-up range from 6 to 60 months, about a little more than 2 years. And we've submitted this data now for publication in a leading medical journal. Just to quickly look at all intravascular imaging with OCT or IVUS versus angiography-guided PCI. I won't go into all the details of this network meta-analysis, but the bottom line is here are the network estimates of the treatment effects. And intravascular imaging overall reduces target lesion failure, that's kind of like MACE, cardiac death, myocardial infarctions, repeat revascularization, stent thrombosis by about 50%. And for the first time, we've been able to show a reduction in all-cause death and all myocardial infarctions just by using intravascular imaging compared to using angiography-guided PCI to optimize PCI outcomes. When we compare OCT-guided PCI to IVUS-guided PCI, they're overall very similar. No significant differences in outcomes with either of those two techniques. And so why does intravascular imaging help us in the cath lab? It gives us better outcomes within the stent and at the edges of the stent. The number one predictor of outcomes within the stent is how large the lumen is within the stent. And we can't tell using an angiogram whether a stent is 80% expanded, 90% expanded, or 100% expanded. It looks exactly the same on the angiogram. But by using intravascular imaging, the larger what's called the minimal stent area is, the better the results. And there's a huge literature on this. Okay, so using intravascular ultrasound, the 3 biggest predictors of adverse outcomes after you put in a stent are if you've got a small stent lumen or if you've underexpanded the stent, if you've got edge problems, that is, if you've got a dissection that you couldn't see angiographically, or if you have a lesion at the edge of the stent that you haven't treated, or if you have intra-stent plaque protrusion, which is probably mostly thrombus. And again, you can't see these things with angiography. And we have the exact same 3 predictors with a dozen studies that have been done with optical coherence tomography, and we'll be presenting the biggest such study at the TCT meeting in about a week. Now, we looked at this with a large registry that we ran called the ADAPT-ES registry, which is a multi-center international study of 8,582 patients, all comers undergoing PCI with drug-eluting stents, and intravascular ultrasound was used in about 39.2% of those cases, and we carefully tracked at the changes that IVUS leads to. And what IVUS does, and same thing OCT, is it changes what the operator does in about 3/4 of the cases. They use either larger stents or larger balloons. They go to higher inflation pressures. They use longer stents. They see incomplete expansion or malapposition, so they do additional post-stent dilatation, or they need additional stents for problems. So 3/4 of the time, compared to what they would have done by angiography, they continue to improve their outcomes. And in this non-randomized study, we saw all the exact same data that I showed you in the randomized meta-analysis with improved both safety and effectiveness outcomes. Now, I also mentioned to you that when you have so-called MINOCA, that's myocardial infarction with non-obstructive coronary arteries, you do an angiogram, you can't see the lesion. You know, is it due to something very strange, such as microvascular disease or vasospasm that's relieved, or is it just something you can't see on the angiogram? And there's been actually about 6 separate studies with about 363 patients that says that when you do optical coherence tomography, you will find the culprit lesion in about half of the cases. You just couldn't see it with the angiogram. So here is a case of a patient that had kind of lumpy, bumpy disease, both in a right coronary artery and in an LAD, and they did 3-vessel optical coherence tomography, and that was the cause of the myocardial infarction. You could see an empty plaque cavity, you could see it recently ruptured, and there's some adherent thrombus. Here's another right coronary, which actually looks pretty normal, except a funny little interesting increased kind of density there, but that's a 5 to 10% stenosis by angiography, and optical coherence tomography shows that that's a ruptured plaque with adherent thrombus. Here's a 41-year-old woman who presented with a non-ST segment elevation, and her coronaries were normal, except for this kind of mild diffuse mid-LAD lesion. So the operator performed OCT, and you see a huge spontaneous coronary dissection with an intramural hematoma, and you just can't appreciate it. All you see with the angiogram is this lumen. You can't appreciate what's going on in the vessel wall. So about half the time, you can diagnose and find the site of the location of myocardial infarction. Some of these should be treated with PCI, some should be treated medically. Now, when we start comparing physiology and acute coronary syndromes to intravascular imaging, we start to see very similar results with intravascular imaging or even better. So in the Flavor trial, this was mostly stable CAD, but it was FFR versus IVUS, no difference in any outcomes out to 2 years for lesion selection. In the Forza trial that was published in JACC Interventions, it was a smaller study, but 350 patients that they randomized to OCT with OCT for lesion selection with OCT optimization versus physiology. And you could see there were actually better results with OCT guidance, lesion selection plus optimization compared to just physiology. So that's kind of what we do today in the cath lab. What about in the future? So I'll address a few of these things, and this touches on what you've heard from the previous speakers. First, let's talk about the detection and treatment of vulnerable plaque. You've heard that about 70% of all myocardial infarctions and sudden cardiac deaths are caused by thrombosis and rupture of these so-called TICFAs, thin-capped fibroatheromas, this well-formed necrotic core, which is cholesterol and cholesterol esters, over which is a very thin, metabolically active fibrous cap, which when it ruptures, releases tissue factor and other prothrombotic contents of the core, and you can convert what was a non-obstructive lumen, this is a wide open lumen here, even though there's this so-called Glygovian remodeling, the plaque on the outside of the lumen, and then it can thrombose over minutes to days or weeks. And if the plaque's not severe, sometimes this may be asymptomatic or cause atypical chest pain and cause a layered plaque and plaque progression, as Jagger was talking to you about. But if it goes on and either closes or nearly closes the vessel, you get an acute coronary syndrome, myocardial infarction, or sudden death, depending on the location of the lesion. Now, we've run a study of prospective studies called the Prospect studies, where we've done 3-vessel imaging with a variety of different intravascular imaging techniques, and we've shown that you can identify these plaques in vessels that have negative physiology, that are non-ischemic. So here, for example, a right coronary artery, this did have a stent that was in the distal portion, but you can see there's no significant lesions. The IFR is 0.95, so it's physiologically normal. And about 3 years later, you could see rapid lesion progression, and this was a non-STEMI right at this site. Now, if we go back here, when we imaged it back at baseline, here you could see this near-infrared spectroscopy, which looks for lipid, and you can see it's all red everywhere in the entire artery except for this one spot. And that's where that big arrow is, where there's an intense deposition of lipid. And when we also look at that spot with superimposed intravascular ultrasound, we could see that that was actually a big, bulky, positively modeled plaque with 80% plaque burden. But you can't tell any of that from the angiogram. So that's a vulnerable plaque. You can also do the same with OCT. You can take FFR negative lesions. Here's about a 30% stenosis, 40% stenosis in the proximal right, and you can see that about a year later, that caused a non-STEMI with subtotal occlusion. When you looked at this back at baseline in this study that was recently published in JACC, you could see it actually had a small minimal luminal area, but more importantly, it had a lot of lipid deposition, about 270 degrees, and a very thin fibrous cap. And only OCT can show you the thickness of the fibrous cap that puts a patient at risk. So if you look at the 3 studies that have been done that looked at 3-vessel intravascular imaging, Prospect with radiofrequency IVUS, Prospect 2 with NIRS IVUS, and then the study recently published in JACC by Jiang with OCT, you can see that by multivariable analysis, the morphologic characteristics of these so-called thin cap fibroatheromas are the ones that with an independent risk of around 3 to 5 times put a patient at risk for future lesion-related events coming from that specific lesion. So the question is, what do we do with this information? Well, we can, I believe, use this information, we got to prove this in randomized trials, to get better outcomes for our patients when we see these lesions in the right clinical setting. So for example, this is one of the probably the best trials that's been published of recent years, the most important, called the COMPLETE trial. And this was not about vulnerable plaque. This was a trial of 4,000 STEMI patients with multivessel disease. And they treated that culprit lesion, and they said, should we treat bystander lesions, intermediate lesions, using angiographic criteria or not? And so they randomized all these bystander lesions. If they were 70% or greater stenosis, they said, we'll do stenting, and if they were greater than, and if not, then we're just going to treat them medically. And there was a big difference in cardiovascular death or new myocardial infarction, particularly new myocardial infarctions, much more unstable angina, and much more patients becoming unstable and requiring repeat revascularization. And this changed practice and changed the guidelines. We now no longer leave bystander lesions behind. But can we do better? And I'll tell you that we can do better. Because when you looked, they did an OCT sub-study. And they found that about 2/3 of these patients had thin cap fibroatheromas left behind. But only about 45% of the thin cap fibroatheromas were in these so-called angiographically obstructive lesions, the ones that were greater than 70%, which is what our indication is to treat them today. We don't have an indication to treat non-obstructive lesions based on the angiogram. But 56% of all of these thin cap fibroatheromas were in mild stenoses, 20 to 70% diameter stenosis. And these were not treated. And actually, if you look by OCT at those obstructive TICFAs, the ones that were treated, and the non-obstructive TICFAs, they look exactly the same. Same amount of lipids, same thin fibrous cap. So we could have, I believe, doubled the treatment benefit had we treated these vulnerable plaques. It's not treating severe angiographic stenosis, it's treating the plaques that are likely to go on and cause events in patients. Now, there's some applications even in stable CAD, and this is from the ischemia trial. David, thank you again for giving me the opportunity to look at this data. We did a very sophisticated analysis from ischemia from the angiographic core lab, looking to see if in stable CAD, do we get complete revascularization? We just published this in JACC a few weeks ago. And we don't do as good a job as we actually think we do. This is the patients, 2,296 patients who were randomized to the invasive strategy, and we only got complete anatomic revascularization in about 44% of all the patients. If you look at functional revascularization, do we actually revascularize all the hemodynamically significant lesions? We're a little bit better, 59%, but not so much better. Now, if we looked at just the invasive arm and compare it to how we might have done in a conservative arm, this was in a propensity weight-adjusted analysis to try to balance the characteristics between the patients. It's a modeling analysis. You can see that overall, this would be the invasive arm in whom we got angiographic complete revascularization on anatomic criteria in all patients, and functional complete revascularization in all patients at the bottom. And you can see that we actually do better with anatomic complete revascularization. Okay, so that's seemed to be the goal that we're looking for. And if you now compare this ischemia analysis to what was actually seen in the ischemia trial, there tended to be about a 2.5% benefit with revascularization in ischemia, which in this non-CABG population was borderline significant out to 4 years. If we do angiographic complete revascularization, we could increase that to 3.6%. Functional revascularization really didn't have much of an effect. So we really need to treat the lesions that are containing the plaques that are going to cause clinical instability, cardiovascular death and myocardial infarction, not just the one that are functionally significant, which will cause symptoms, but not necessarily clinical instability. Now, I will say we need prospective randomized trials before we treat vulnerable plaque. Jagat showed you the pilot study that we did, the prospect absorb study, which showed we could safely treat these, safely enlarge the lumens. We had underpowered trends towards improved outcomes. There's now 5 randomized trials and more than 12,000 patients that are ongoing to look at the interventional treatment of vulnerable plaques. The last thing I'll close on is post-PCI physiology. So far, I've just talked to you about pre-PCI physiology. But the other reality is that whether it's surgery or whether it's intervention, we don't do a great job at relieving angina. And if you look here, about 1 year after PCI, 20 to 40% of patients have recurrent angina. And this is much higher than the restenosis rate of lesions with our current drug-eluting stents. We looked at this most recently in prospect absorb with very sophisticated analysis, 39% recurrent angina at 1 year, despite treating mostly non-complex lesions. And one of the reasons is that we're not doing a great job revascularizing patients on the basis of angiography and pre-PCI physiology and stable CAD. This was initially brought up from the FFR literature, where after successful PCI, 20% of those target vessels still have an abnormal FFR of less than 0.8. And if you continue to try to improve the stent results, you can reduce that number. We looked at this carefully in the defined PCI registry in 500 patients looking at IFR, a non-hyperemic technique. And overall, we increased the IFR by treating the lesions, but 24% of them still have an abnormal IFR. When we look at those abnormal IFRs, about 4/5 of them were from a focal area, but they're not always related to the stent. About a third of them are proximal to the stent, a third of them are in the stent, and a third of them are distal into the stent. And if we could treat all of these 80% focal lesions, okay, the rate of significant ischemia could theoretically be reduced from 24% to 5%. And again, you can't see these things angiographically. If you look at the diameter stenosis, they look exactly the same whether or not there is residual ischemia after PCI. So here, for example, this kind of long diffuse LAD lesion, the IFR is very, very low. It's very abnormal. A stent is put in here. Stent result doesn't look so great, but that's the result. They then perform post-PCI physiology, and they get 0.74, which is still very abnormal. It's less than 0.89. And then when you look, though, where the lesion is, where is the physiology, what's wrong with that stent? Nothing's wrong with the stent. There's no step up in physiology in the stent at all. The problem was that. And they didn't treat that, and that was an unsuspected lesion that had a marked abnormal gradient. And it may not be enough just to create a non-ischemic scenario. When we actually looked at the predictors of adverse outcomes at 1 and 2 years, we needed to get the IFR up to about 0.95 to be able to prevent death and myocardial infarction, or to be able to be associated with the prevention of death and MI. So an IFR of around 0.95 correlated most strongly with freedom from both cardiac death or spontaneous MI. Here's the cases with greater than or equal to 0.95 versus less than 0.95. Again, no deaths or MIs in the patients where there was really no gradient down the vessel versus 3.2%. And here's the MACE rates. And there were less symptoms in the patients that had an IFR of less than 0.95. So this has led us to run a trial that we're currently enrolling in, which is defined GPS. This is overall about somewhere between 2,000 and 3,000 patients in who we're doing successful PCI, and then we're randomizing patients to Physiology with IFR along the entire course of the vessel versus just leaving it alone because you think you got a successful result. And we're trying to optimize all the untreated results to try to drive to an IFR of 0.95 or greater. And we've randomized well over 1,000 patients in this trial so far. The third future area that I'm not going to get into, I took these slides out because of time, is the routine assessment for microvascular disease and vasospasm. And this is really an interesting growing area because I think that contributes to at least half of those cases of ongoing angina and ischemia, even when there's no significant epicardial coronary stenosis. And we can assess some of that in the cath lab, and there are new therapies that are being investigated for that, one of which is a treatment in the coronary sinus called the reducer that we and others are investigating. So if I were to summarize, there are complementary roles of intravascular imaging in physiology. Invasive pressure wire-based physiology, both hyperemic and non-hyperemic, is currently the gold standard to identify lesions that should be revascularized in stable CAD, class 1. Except for the left main, where either IVUS or FFR or IFR, at least with IFR, FFR, if there's no major branch disease, probably is as good. And I didn't show you that data because of time. Intravascular imaging, especially OCT, is useful to identify indistinct culprit lesions that cause ACS. Intravascular imaging is useful before PCI to gauge the need for and the adequacy of plaque modification and to plan the PCI procedure. And it's useful post-PCI to assess the stent parameters that predict outcomes, and thus must be identified and optimized. Now, for the future, complete anatomic revascularization affords a better prognosis than ICR. In acute coronary syndromes and STEMI, it's been proven. In stable CAD, we've got associative studies, possibly due to treatment of vulnerable plaques. And identification and treatment of vulnerable plaques with intravascular imaging may represent a paradigm shift in the practice of PCI. We'll see what the results of the ongoing trials are. Finally, a substantial proportion of vessels after PCI remain ischemic due to suboptimal stent implantation, untreated epicardial disease, and/or microvascular disease or vasospasm, contributing to high rates of recurrent angina and increased MACE during follow-up. Pre-PCI and post-PCI physiology may identify suboptimal PCI results and those lesions that you wouldn't have treated in the first place, the treatment of which may improve prognosis, and ongoing randomized trials will address this issue as well. Thank you very much.